أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. I am Professor Syed Ali Haidar. I am visiting professor of Genus in Medical University, and I am actually doing the clinical chest radiology reporting now. Reporting sessions are there. Previously, I have discussed 6 X-rays and reported in front of you. So one should know how to present the X-ray actually, how to report it correctly. Now this is the X-ray chest number 7. 6 has been done. Now the case scenario is that at 32-year-old vaping addict who was known hypothyroid and was on drugs and also on antidepressants and he was also on the antihypertensives, was attacked with a fever with rigors or chills and shortness of the breath for the last 7 days. And he had just completed the course of the broad spectrum antibiotics, presented now with tepapnea, right side of the tepapnea 2 days back. What is tepapnea? What is orthopnea? That is the shortness of breath on lying flat. One is called the tepapnea. It is the shortness of breath while lying on the one side, on the right lateral side or the left lateral side. And one is called platypnea, meaning that there is shortness of breath when he sits and he bends down anteriorly. That is called platypnea. The tepapnea is one of the signs of the congestive cardiac failure, no doubt, but it is a sign of the actually increase in the interthoracic pressure also. The tepapnea, right side, 2 days back. On examination, the temperature was 101, pulse was 110 per minute, blood pressure was 160 by 100, and it is definitely higher. Tachycardic patient, respiratory rate is slightly higher, 21 per minute tachypneic, reduced chest movements on the left lower chest wall on inspection. Trachea was central on palpation, and TBF was reduced on the left lower chest. And on percussion, there were stony dull notes from left intercostal space downwards to the left 8th intercostal space on the anterior axillary line with the nil breath sounds, and there was reduced vocal resonance. The investigation was hemoglobin 13 gram. The total leukocyte count was 12,500. Neutrophil 76%, lymphocytes 24%. ESR was 54 millimeter. The random blood sugar was 178. Urine, the RE was normal. While X-ray test was done and presented to you for the reporting. We are going to report this X-ray now. Reporting X-ray test. The requirements is that it should be PA view. It is PA view because the vertebral column is masked by the middle mediastinum and the supraclavicular foci are wide enough. The other requirement was S plus S plus S. One was standing. He was standing first, second, third, fourth, fifth. He is standing. Second one is it should be straight. Now, patient has moved his neck on this side because of anything. We don't know why he has done that. We don't know about it. But he's bended his neck on the right side, and that is why he is not straight. The spinous process is going in this direction. Probably he has got a scoliosis or something, kyphoscoliosis. I cannot comment on this because the lateral view is not present. So he was not straight. And because he was not straight, one line is drawn here, one line is drawn here. There should be 90-degree angle on the both sides. So trachea cannot be described whether it is shifted actually or not. On the clinical examination, the trachea was central. And here it is definitely bending here in this case. more than 10 degree on the right side, but it is due to the malposition of the patient. And third requirement was still that he has taken the deep breath. He has deep breath because eighth rib is there, and hold the breath properly because the bronchovascular markings are visible very clearly and they are not admixed. It means it is not expiratory film. The bony skeleton here, clavicles and the other bones seems to be normal, although there is a chance of because of the bending of the kyphoscoliosis, the vertebral spine, deformity, possibility of it. Otherwise, the first rib, second rib, third rib, first intercostal space, second intercostal, third, fourth, fifth, sixth, on this side, upper border, lower border of the rib, they are normal, and the intercostal spaces here, you can see these are reduced spaces. Because of the pathology there, or because of the kyphoscoliosis. The chances are there that the vertebral deformity causing this restricted movement of the chest. Therefore, intercostal spaces are narrow, and it can cause the restricted type of lung disease later on. Now, after this is the scapulae. The medial border is out, and the cervical spine is seen here. The intervertebral spaces, and these are the spinous processes. These are the transfer processes. No cervical rib or accessory ribs evidence is there. Afterwards, the trachea cannot be commented on, so lung fields are describing. The apice is with the apices, first intercostal with the first, second with the second, comparison is done. On the comparative study, we find there is a congestion here in this side. The bronchovascular markings are touching on the right side to the lateral wall. It means there is a congestion on this side. It may be possibly of the high blood supply on the right side, because of there is then definitely here there is a pathology which restricts the lung function on the left side. On the left side, you see the diaphragm, the costophrenic angle and the cardiophrenic angle are normal, but on this side the cardiophrenic angle and the costophrenic angle are blocked, and there is a single opacity which is homogeneous in nature, and there is a definitely curve above it. Definitely a curve above it. This is meniscus sign or Ellis's sign. And above it, there is congestive changes are seen. To me, it seems to be a stage of resolution, because global pneumonia occurs in 4 stages. Stage of congestion, a stage of red hepatization, a stage of grey hepatization, and a stage of resolution, in the resulting phase. And because the meniscus sign is positive, this is what is known as the pleural effusion. On the left side was there. And about the middle meristem is concerned, Salot sign is positive because the borders are blocked. You cannot comment on the size of the heart or the shape of the heart. The upper part of the middle meristem is describing here. So it is divided into 4 parts for the learning purpose, equally like this. The first part denotes the ascending aorta, the second and third will the arch of aorta, and there is the aortic knuckle, and the fourth one is the pulmonary conus. So it's normal. And the hyla on this side is not visible on the left side. Although this small part is seen here, on the right side it is visible very clearly. Size is normal, the shape is normal. The upper branch, the lower branch, they are thick bronchovascular markings coming out. And this is the stem, which is measures about 1.5 to 2 centimeters, is normal. So there is no evidence of lymphadenopathy hilar. So inference, the conclusion is this, that the person has the evidence of the homogeneous opacity with a curve above it, means Ellis's curve, and this is the diagnostic point in this case, is that he is suffering from or has been suffering from the pleural effusion, most probably. Now, pleural effusion with Ellis's curve, definitely. And it is a paranomic to me because the upper part showing the signs of resolution. Here is the bronchovascular markings, they are coming out, and resoluting phase is seen here. So this is how I reached it. Etiology is concerned that other than that, differential diagnosis can be made. Acute inflammation or the result of acute inflammation. It is a paranomic pleural effusion, okay. What about the chronic inflammation? It may be tuberculosis in nature, tuberculosis pneumonia. It's possible of fungal infection, yes. It's a possibility of a malignancy, malignant pleural effusion. Possibility is there. Chances are less. The allergic conditions, the pneumoconiosis, the autoimmune diseases, the sarcoidosis, and the parasitic infestation can cause pleural effusion. Other than that, there are other causes as well. Uremia can cause pleural effusion. The hypothyroid, he was hypothyroid also. It will also cause the pleural effusion. What type of a pleural effusion? It is transudate or exudate. You go for the therapeutic diagnostic pleurodesis first. You remove the fluid and examine, and the serum albumin was also taken at the same time with the left T. Then we give what we call as the SPAG, SPAG, that is serum pleural fluid, serum pleural fluid gradient. It is SPLG, pleural SPFG. In the abdomen, ascites was assessed by the SAG. Here we will use the terminology rather than ascitic fluid because it is the pleural fluid. So we use the terminology the SPA. So if it is more than 1.1 or 1.2, it means that it is transudate. If it is less than this, exudate. Other thing is more than 2.5 gram protein ratio of the serum protein to the pleural fluid protein is definitely more than 1.5, and other parameters as well. You know that about it. I don't want to discuss here, but this is how we reach the diagnosis. Anyway, so I will, in the conclusion, after inference, I will go to conclude it. Whether I want to do the further investigation, yes, the left lateral X-ray chest should be done, HRCT should be done, the sputum AFB should be done, and you will also do the other, the left T, the creatinine electrolytes, and you also can do the urine for the pneumococcal antigen, just to do it, and blood culture also. But these cases are ending up in the septicemia or bacteremia leading to septicemia. All should be done to reach the final diagnosis. To relieve it, the pleural fluid should be out. That is called the therapeutic pleurosynthesis. As much as fluid you can take out is good. If it is exudate, but it's a pyogenic exudate, but it's called empyema, you have to go for the underwater seal. So you can deal yourself this patient, otherwise you will refer to the pulmonologist. They do accordingly. So this is the conclusion of my this X-ray which I have presented to you. I think you have understood it well, and you also appreciated my efforts to describe it, rather I will say. Inshallah, we will meet again for the another X-ray 8, number 8, and then we will describe it and report it. Try to report yourself. Inshallah, we will meet it again. Meet you again. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamu alaikum wa rahmatullahi wa barakatuhu. Wa ma alayna illa al balagh.